Hello, everyone. Welcome to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever your curiosity calls. I'm Naya, your host for today's episode, and I'm joined by Leen Hakki, where we will be discussing oral cavity, infectious diseases, and everything in between.
Hi everyone, it's Leen. I'm excited to be here. Let's dive right into our discussion. We'll start with something super common. So here's a case. A 23-year-old student comes in with a painful shallow ulcer on the inner side of her lip. It's got a yellow-white base and a red halo around it.
Yep, that sounds like an aphthous ulcer, tiny but really painful, also known as a canker sore. Am I right?
Exactly. Aphthous ulcers are painful recurrent superficial ulcers that show up on the oral mucosa, especially in younger individuals. The lesions are typically solitary, round or oval, with a white base surrounded by a reddish rim.
Okay, so what are the known causes?
They're usually idiopathic but can be associated with stress, trauma, or nutritional deficiencies. Occasionally, they appear in systemic diseases like Behçet syndrome.
Right, so now can you tell me what we would see under the microscope?
You'd find a mononuclear inflammatory infiltrate, primarily lymphocytes, and ulceration of the epithelium with a fibrinopurulent membrane.
And what about the treatment?
It's usually not needed. They heal spontaneously in 7 to 10 days, but if one needs symptomatic relief, topical corticosteroids can be used.
Okay, great. Now, moving on, what are we discussing next?
Okay, so now consider this. A 4-year-old child presents with fever, irritability, and painful oral ulcers involving the lips, gingiva, and a hard palate. You also see some vesicles on the vermilion border.
Wait, I think I know what this is. Is this classic primary herpetic gingivostomatitis?
Exactly. It's caused by HSV1, which is usually the primary infection in children between 2 to 4 years. It presents with numerous vesicles and ulcers affecting both keratinized and non-keratinized mucosa, especially the gingiva and palate.
Okay, I see. So, how does the virus behave long term?
So basically, after the primary episode, the virus becomes latent in the trigeminal ganglia. It can later reactivate as recurrent herpes labialis, those classic cold sores.
This is actually really interesting. Can you tell me how do they appear under the microscope though?
So basically, what you'd see is multinucleated giant cells, internuclear viral inclusions, and ballooning degeneration of epithelial cells.
And how about the management?
Basically, for primary infections, it's mostly supportive. In severe cases or in immunocompromised patients, you can use acyclovir.
Okay, I see. So now, just to summarize, multiple vesicles that ulcerate following fever and gingival involvement, it's HSV. And if the ulcer is a single, painful one with no fever, we think of aphthous.
You're right. Distinction between them helps guide treatment.
So now let's kick things off with something most of us have had at some point, cavities.
Yep. So picture a 10-year-old boy coming in with tooth pain whenever he eats sweets. His mom says he's a soda lover and not the biggest fan of brushing.
Oh, okay. So seems like a classical setup for dental caries.
It all starts with Streptococcus mutans. This little guy loves sugar and loves teeth. It sticks to the enamel using special surface proteins, forms a sticky biofilm, and ferments sugar into lactic acid.
Wait, which then drops the pH and starts eating away at the enamel, right?
Bingo! Once the pH goes below 5.5, hydroxyapatite in the enamel starts to dissolve. The bacteria basically make themselves a cozy little home and throw an acid party.
Oof, sounds like the worst kind of guest, honestly.
Oh, totally. And they even bring friends like lactobacillus and actinomyces to help build the nasty plaque. Now take that same kid and fast forward a few decades. If he never changed his habits, he's now a 49-year-old with swollen bleeding gums.
I guess now we're in gingivitis territory.
Yep, plaque-induced inflammation of the gums. But if it goes unchecked, it can evolve into periodontitis. Then that's where things get nasty.
So you mean bone loss and wobbly teeth, right?
Exactly. The bacteria dives deep under the gum line, mainly P. gingivalis, Treponema denticola, and the gang.
And how do we deal with this?
Aggressive oral hygiene and sometimes even surgical cleaning could be needed because once a bone is lost, it's tough to get it back.
All right, so now let's talk about two other lesions that show up in the oral cavity, fibroma and pyogenic granuloma. Tell me something about it.
Okay, Naya. Let's start with fibroma. It's actually the most common benign tumor in the oral cavity, and it's not a true neuroplasm. It's a reactive hyperplasia of fibrous connective tissue. It's usually caused by chronic irritation like cheek biting or sharp dental edges.
Okay, and what does that look like exactly?
It shows up as a firm, painless nodule, often on the buccal mucosa along the bite line. Histologically, you'll see dense fibrous tissue covered by squamous epithelium.
Okay, and how about when it comes to pyogenic granuloma?
It's a totally different thing. Despite the name, it's not pyogenic and not a granuloma. It's an excessive granulation tissue that often arises from trauma or irritation, especially during pregnancy. That's the nickname pregnancy tumor.
And how does that present like?
It's a red, soft, ulcerated, and often a bleeding mass, typically on the gingiva, but can also appear on the lips or the tongue. It can either regress or undergo fibrosis.
Okay, so our takeaway here is fibroma is firm and fibrous. You can remember this with FFF. And pyogenic granuloma is red, vascular, and bleeds easily.
Exactly. Remember, both are benign, but they look and behave very different.
Okay, now let's talk about some serious infections. The name alone sounds really scary in my opinion. Vincent's angina.
Oh, for sure. It's also known as acute necrotizing ulcerative gingivitis or trench mouth, named after World War I soldiers who often got it in the trenches due to stress, poor hygiene, and malnutrition.
That already gives us a hint at the risk factors.
Exactly. Think poor oral hygiene, smoking, immunosuppression, stress, and nutritional deficiencies, especially vitamin C. It's more common in young adults or immunocompromised individuals.
Alright, so how does it actually develop?
It's polymicrobial, primarily caused by anaerobes and spirochetes, including Fusobacterium nucleatum, Borrelia vincenti, and Treponema. These organisms invade the gingival sulcus, destroy the epithelium, and cause ulceration and necrosis.
Oof, that sounds like a lot of damage, honestly. But can you tell me about the clinical picture?
Sure. There's sharp gum pain, bleeding, halitosis, metallic taste, and grayish pseudomembranous slough on the gingiva. You'll see cratered ulcers between the teeth and sometimes lymphadenopathy or fever if it's severe.
Okay, so I have a question though. Is it usually localized to the gums only?
Mostly, but if it spreads deeper, it can lead to necrotizing ulcerative periodontitis, NUP, or even necrotizing stomatitis, which is more aggressive and affects soft tissue and bone. We usually diagnose it clinically by history and a good physical exam, and microbiology using gram stain to show the culprit bacteria.
And when it comes to the treatment, how do we deal with that?
It's a combo: mechanical debridement, chlorhexidine rinses, and antibiotics like metronidazole or penicillin. And of course, you've got to fix the predisposing factors. So improve oral hygiene, nutrition, and treat underlying illness.
So bottom line, it's painful, nasty, but totally preventable.
Couldn't have said it better. All right, moving on. This next one's no joke. A man shows up to the ER with a rock-hard swelling under his jaw, drooling, muffled speech, and difficulty breathing. He had a dental infection a few days ago.
Wait, that firm board-like swelling is such a giveaway. That's Ludwig's angina, isn't it? And the danger here is airway obstruction, right?
Exactly. Ludwig's angina is a rapidly progressive cellulitis of the submandibular, sublingual, and submental spaces, often bilateral. The floor of the mouth becomes elevated and pushes the tongue up and back, which can obstruct the airway.
Oh, so what's usually the source of infection?
Usually the most common origin is an infected or recently extracted second or third mandibular molar. The roots of these teeth are close to the submandibular space.
Okay, so microbiology-wise, what bugs are we exactly talking about?
Usually it's polymicrobial. You'll find aerobic and anaerobic flora from the oral cavity. Common organisms include Streptococcus viridans, Staphylococcus aureus, Fusobacterium, Prevotella, and Bacteroid species.
And once it spreads, it won't form an abscess, right? Also, is it more like diffuse inflammation?
Exactly. Unlike localized abscesses, Ludwig's angina is a diffuse cellulitis, which makes it even more dangerous because there's no clear pus pocket to drain initially.
So the main goal is protecting the airway.
Right. Airway management is the absolute priority. Many patients require intubation or tracheostomy. Then you follow up with IV broad-spectrum antibiotics covering both aerobes and anaerobes, like ampicillin sulbactam, clindamycin, or penicillin plus metronidazole combo.
Okay, so to summarize, diffuse neck cellulitis from a molar infection, rapid airway compromise, polymicrobial, manage the airway first, treat with IV antibiotics, and monitor closely.
Perfect summary. And don't forget to educate the patient on dental hygiene and early care to prevent this from happening in the first place.
So let's talk about fungal infections for a second. What's the most common oral fungal infection out there?
Okay, definitely candidiasis, caused by Candida albicans. It's part of the normal flora, but when the balance tips, boom, it turns pathogenic.
So what tips the balance?
Lots of stuff. Locally, poorly fitted dentures and bad denture hygiene. Systemically, you've got things like extreme of age, diabetes, antibiotics, steroid inhalers, and of course, immunosuppression. HIV, chemotherapy, transplant patients.
And candidiasis has other types too, right?
Yes, the most classic one is pseudomembranous candidiasis, aka thrush. You'll see creamy white plaques on the tongue, cheeks, or palate that scrape off and leave a raw red base. Common in babies, elderly, and anyone sick or immunosuppressed.
Also, there is erythroplakia candidiasis, right?
Exactly. Red, sore areas, often on the tongue or under dentures. It's especially common after antibiotic use or in HIV positive patients. There's also denture-related stomatitis, angular cheilitis, hyperplastic candidiasis. The works.
Now, finally, how do we treat such a case?
Topical antifungals like nystatin or oral fluconazole for more stubborn cases. And always remember to fix the underlying issue. Clean those dentures, don't sleep with them in. Moving on, let's look at our next patient. A 7-year-old boy comes in with sudden onset severe throat pain, fever over 38 degrees Celsius, and difficulty swallowing. His mom says he hasn't had a runny nose or cough. On exam, you find red inflamed tonsils with white exudates, tender anterior cervical lymph nodes, and petechiae on the soft palate.
I think all signs are pointing to group A strep pharyngitis, right?
Yep. Streptococcus pyogenes, also known as group A beta hemolytic streptococcus, GAS, is the culprit. It's a gram-positive cocci in chains, catalase negative, PYR positive, and bacitracin sensitive. It shows beta hemolysis on blood agar.
And how does it exactly spread?
They spread through respiratory droplets. It's especially common in kids aged 5 to 15, mostly during the fall and winter.
So, what clinical features help us distinguish it from viral pharyngitis?
Of course, the big ones. No cough or runny nose, sudden onset, high fever, tonsillar exudates, and tender anterior cervical adenopathy. You might also see petechiae on the palate, and in severe cases, scarletiniform rash or strawberry tongue if scarlet fever develops.
Then, how do we confirm the diagnosis?
Okay, so start with a throat swab. A rapid antigen detection test, RADT, gives quick results. But because it isn't 100% sensitive, a throat culture should be done, especially in children. Molecular tests like NAATs should also be used.
And what are the post-infectious complications?
2 main ones, rheumatic fever and post-streptococcal glomerulonephritis. To assess previous infection, we can use serologic tests like anti-streptolysin O and anti-DNase B titers.
Okay, Leen, can you walk me through the treatment protocol?
Sure. Usually, 10 days of penicillin or amoxicillin. For penicillin allergic patients, macrolides like azithromycin can be used. Treatment shortens illness, prevents complications, and limits transmission.
So the takeaway here is sudden sore throat, fever, no cough means that you should test for strep, treat early, and don't ignore the long-term risks.
Exactly, Naya. One of those infections where early action makes a big difference. Okay, next, one's a bit of a throwback, but still important. A 6-year-old, partially vaccinated girl presents with low-grade fever, sore throat, and a thick grayish membrane over her tonsils and pharynx. Her neck looks swollen, classic bull neck.
That sounds like diphtheria.
Bingo! Caused by Corynebacterium diphtheria, a gram-positive, club-shaped rod that often forms palisades or V formations under the microscope. What really makes it dangerous is its exotoxin.
Right, I think the toxin's the real villain here.
You're right. The diphtheria toxin is an AB exotoxin. The B subunit binds to the host cell receptors, specifically the heparin-binding epidermal growth factor receptor, especially abundant in heart and nerve tissue. That explains the cardiac and neurologic complications.
And what does the A subunit do again?
The A subunit completely halts protein synthesis. It literally shuts off the cell's ability to make proteins, leading to cell death.
That's brutal. And the toxin is only produced by strains carrying the tox gene, right?
Exactly. The gene is encoded on a lysogenic bacteriophage. Without the phage, the bacterium can't make the toxin.
Okay, can you tell me the different types of C. diphtheria again?
They're classified into 4 biotypes based on colony morphology and biochemical properties: gravis, mitis, intermedius, and belfanti. Most human disease is caused by the mitis biotype, which tends to produce higher levels of toxin.
Okay, so back to the case, that pseudomembrane, that's made of necrotic tissue and bacteria, right?
Yep. Plus fibrin and inflammatory cells. It's tightly adherent, and trying to remove it can cause bleeding. If it spreads to the larynx or trachea, it can cause airway obstruction, which is life-threatening.
So, how do we confirm the diagnosis in the lab?
Basically, microscopy isn't very reliable, but on methylene blue stain, you might see metachromatic granules. Culture is done on special media like Tinsdale agar, CTBA, and Loeffler's medium.
So, how do we check if the strain makes the toxin?
Gold standard is the ELIC test, an in vitro immunodiffusion assay. You can also use PCR to detect the tox gene.
So, now to wrap it up, how do we treat it?
Give diphtheria antitoxin immediately. It neutralizes unbound toxin, then start antibiotics like erythromycin or penicillin to clear the bacteria. Supportive care for airway management is crucial, and of course, DTaP vaccine for prevention.
Got it. So, vaccines save lives basically, especially when it comes to something like this. All right, shifting gears, let's talk about viruses, starting with Epstein-Barr virus. What is it known for again?
EBV is like that one virus everyone's probably had but didn't realize it. Most people get exposed to it by adulthood. It spreads through saliva, so yep, the kissing disease.
So, that's infectious mononucleosis, right? How does that show up clinically though?
Picture a college student coming in with weeks of fatigue, sore throat, and swollen neck. On exam, tonsils covered in white patches, petechiae on the palate, and big, tender lymph nodes. That's your classic mono case.
And what's happening under the surface?
Basically, the virus hits the pharyngeal epithelium, then goes after B cells. The incubation period, a solid 4 to 7 weeks. So it brews silently.
How do we confirm it's EBV though?
Well, you'll see atypical lymphocytes on a blood smear, and the monospot test looks for heterophile antibodies. PCR can also detect EBV DNA.
What about the complications?
Big ones. EBV is an oncogenic virus. It's linked to some cancerous conditions such as 1. Burkitt's lymphoma, seen in Africa, associated with malaria. 2. Nasopharyngeal carcinoma, more in Southeast Asia and associated with nitrosamines from preserved fish. 3. In immunocompromised patients, you get hairy leukoplakia.
That's the white plaque on the side of the tongue that doesn't scrape off, right?
Absolutely. Hairy leukoplakia is a white patchy lesion that shows up on the lateral borders of the tongue. It's strongly associated with EBV and seen almost exclusively in immunocompromised patients, especially those with HIV or AIDS.
So when you say hairy leukoplakia, what's that about?
It refers to the corrugated or shaggy appearance of the lesion. It looks kind of fuzzy or ridged, and here's the key part. It doesn't scrape off. Unlike candidiasis, it's not pre-malignant, but it is a red flag for underlying immune suppression.
So if we spot it, we should probably screen the patient for HIV or other causes of immunodeficiency.
Exactly. Treatment isn't usually needed unless it's symptomatic, but improving the immune status can lead to resolution.
So white patch, lateral tongue doesn't scrape off, EBV positive, and usually in someone immunosuppressed. That's hairy leukoplakia.
Yep, perfectly summed up.
Okay, let's go into the classic childhood viruses that love to show up in the mouth.
All right, imagine this. A 5-year-old boy comes in with a high fever, cough, runny nose, and red, watery eyes. The mom says a rash started on his face and spread downwards, and he hasn't had his vaccines.
Oh, it's measles for sure, isn't it?
Yep. And before that rash even appears, you might catch those bluish-white spots on the inside of the cheek. Koplik spots. They look like grains of salt on a red base.
That's super specific for measles, right?
Yep. It's caused by a paramoxyvirus, single-stranded negative sense RNA, and spreads through respiratory droplets. Super contagious. The incubation period is about 7 to 14 days.
And after the Koplik spots?
A maculopapular rash starts at the hairline and works its way down. And the complications? Not fun. Otitis media, pneumonia, encephalitis, and even a rare but fatal one called subacute sclerosing panencephalitis.
Yikes. So prevention is all about the MMR vaccine.
Exactly. Now, mumps. Let's say a teenager walks in with a swollen jaw, complains that it hurts when chewing, and he looks a little puffy around the ears.
Sounds like periodontitis, classic mumps.
Totally. It's also a paramoxyvirus. The incubation's a bit longer, 14 to 28 days. You'll get fever, headache, malaise, and that painful swelling of the parotid glands.
And chewing or eating sour foods makes it worse, right?
Yep. And in postpubertal males, watch for orchitis, which can lead to infertility. Other rare complications include meningitis and hearing loss.
And how about the diagnosis?
Mostly clinical, but serology can confirm it. Again, prevention is the same deal, MMR vaccine. Now, it's time to talk about some precancerous stuff.
All right, let's dig a bit deeper into leukoplakia. which is slightly complex.
Okay, so leukoplakia is actually the most common precancerous lesion of the oral cavity. It's a white patch or plaque on the mucosa that can't be scraped off and can't be explained by another disease like candidiasis or lichen planus.
So it's a diagnosis of exclusion, right?
Exactly. You've got to rule out everything else, and it usually shows up in older men, especially those with risk factors like smoking, alcohol, or chronic irritation, such as indentures or sharp teeth.
And what locations should we worry about the most?
Good question. High risk sites include the floor of the mouth, ventral tongue, and soft palate. Lesions here are most likely to show dysplasia or even early squamous cell carcinoma.
Now, when it comes to under the microscope, what would we see?
Usually, it would depend on the stage. You might just see hyperkeratosis, or you might get epithelial dysplasia, disorganized layers, nuclear atypia, increased mitotic activity. In severe cases, it can be carcinoma in situ. Around 5 to 25% of leukoplakia cases will turn malignant over time, and the risk jumps if the lesion looks nodular, speckled, or verrucous.
And if we were to see one, what would be the action?
Biopsy it. Always. You need histology to know what you're dealing with. If there's dysplasia, surgical excision is usually recommended. If not, you still want regular follow-up and definitely get your patient off any risk factors: tobacco, alcohol, mechanical trauma.
So, to wrap it up, white lesion that doesn't scrape off, biopsy it and stay alert for cancer.
Exactly. It might look harmless, but it could be the beginning of something serious.
Okay, so now, what about erythroplakia?
Erythroplakia is rare, but way more dangerous. It looks like a red velvety patch, usually asymptomatic but very sinister. Histologically, it almost always shows severe dysplasia, carcinoma in situ, or even squamous cell carcinoma.
So basically, even though it's less common, it's got a much higher risk of malignancy, right?
Exactly. Up to 90% of erythroplakia lesions show severe dysplasia or worse. That's why they're always biopsied.
And just to round it out, hairy leukoplakia, we already mentioned, EBV associated mostly in immunocompromised folks and not considered pre-malignant. Okay, listeners, finally, last big case for today.
Let me paint the case for you. A 50-year-old man comes in complaining of a non-healing ulcer on the side of his tongue that's been there for over 3 weeks. He smokes a pack a day, drinks occasionally, and says the lesion bleeds when he eats. On exam, there's a firm, irregular white and red patch with induration on the lateral tongue.
This is definitely concerning for squamous cell carcinoma.
Right. Oral squamous cell carcinoma accounts for about 90 to 95% of all oral malignancies. It's more common in men over 50, though younger people are being affected more often now, especially due to HPV.
Okay, so can you tell me about the big risk factors?
Classics are tobacco use, both smoking and smokeless, and alcohol consumption. But chronic mechanical irritation, betel nut chewing, poor oral hygiene, and HPV infection, particularly type 16, also play a big role.
And these cancers, where do they usually show up in the mouth?
Most commonly, the floor of the mouth, ventral tongue, lower lip, and soft palate. These areas are exposed to irritants and have thin, non-keratinized mucosa. The most common type is squamous cell carcinoma. There are 2 big categories: HPV-associated and non-HPV-associated squamous cell carcinomas.
How about we start with the traditional non-HPV kind?
Sure. So, non-HPV is linked to classic risk factors like tobacco use, heavy alcohol intake, and chronic irritation. Think dentures or betel nut chewing. It usually affects older adults, and common sites are the floor of the mouth, ventral tongue, and lower lip.
And when it comes to its histology?
You'll often see keratin pearls and intracellular bridges, classic signs of well-differentiated squamous cell carcinoma. It tends to present late and has a worse prognosis compared to its HPV-positive counterpart.
All right, great. So what's different about the HPV-positive squamous cell carcinomas?
So the difference is these tend to occur in younger patients who don't have a history of smoking or drinking. Most often, they affect the oropharynx, especially the tonsils and base of the tongue.
Okay, and prognosis-wise, what exactly goes on?
HPV-positive squamous cell carcinomas generally respond better to treatment and have a better prognosis. That's partly because they're less genetically unstable than non-HPV tumors. They're usually P16 positive on immunohistochemistry, which is a helpful marker.
So we've got older, smoker, keratinizing squamous cell carcinoma on one hand, and younger, HPV-driven, P16 positive squamous cell carcinoma on the other.
Exactly. 2 different stories, but same endgame. Early detection is key.
Okay, listeners, let's throw in a quick quiz. A 40-year-old man presents with swelling under the jaw, drooling, and trouble speaking. He had a dental abscess earlier. What should you do first? A. Oral antibiotics. B. Incision and drainage. C. Secure the airway. Or D. Dental extraction.
And the answer is C. Always secure the airway first in Ludwig's angina.
Because nothing else matters if the patient can't breathe. Now, on to our next question. Which of the following is a hallmark lab feature of EBV mononucleosis? A. Neutrophilic leukocytosis. B. Eosinophilia. C. Atypical lymphocytosis. D. Thrombocytopenia.
The correct answer is C. Atypical reactive lymphocytes are typical of EBV.
Precisely. Now, moving on, what is the estimated malignant transformation risk of leukoplakia? A. Less than 1%. B. 5 to 25%. C. 50%. D. More than 80%.
B. Between 5 and 25% may progress to squamous cell carcinoma.
All right. Now, before we wrap up, let's just do a quick recap of everything we tackled today because, wow, that was a lot of oral pathology and infections.
Right? We started off with the basics: aphthous ulcers, painful round little guys on the lips or cheeks, non-infectious, usually stress-triggered, and they heal on their own. While HSV ulcers are clustered vesicles on the gingiva or hard palate, usually in younger kids, latent in the trigeminal ganglia and reactivates as cold sores. Look for multinucleated giant cells on Sank smear.
And then there's fibroma, a firm, painless reactive lesion from chronic irritation, and pyogenic granuloma, which sounds scary but is really just a red, bleeding vascular growth common during pregnancy.
Next came dental caries, which were caused by Streptococcus mutans doing its thing with acid and sticky biofilms. Then we moved into gingivitis and periodontitis. The whole progression from puffy gums to full-blown bone loss with the usual suspects like P. gingivalis.
Can't forget Vincent's angina or trench mouth, that nasty necrotizing infection caused by anaerobes and spirochetes, especially in stressed or immunocompromised people.
And then came Ludwig's angina, probably the scariest of the bunch. It starts from a dental infection and ends with a potential airway emergency if you're not fast.
Switching gears to fungal stuff, oral candidiasis came in all forms: pseudomembranous, erythematous, even angular cheilitis. We broke down who gets it and how to treat it.
Then came the viruses, EBV with classic mono and oral hairy leukoplakia in immunocompromised patients, plus measles with Koplik spots and mumps with swollen parotids and risk of orchitis.
And we moved on to the precancerous side, leukoplakia and erythroplakia. The former is more common, the latter is more dangerous. If it doesn't scrape off and you don't know what it is, biopsy.
And of course, oral squamous cell carcinoma, distinguishing the HPV positive ones from the tobacco alcohol associated types. Different causes, different prognosis.
We also squeezed in Group A strep pharyngitis, talked through a classic kid case, how to test, how to treat, and what scary stuff to watch for if you don't.
And we went on a deep dive into diphtheria, bull neck, gray membrane, toxin shutting down EF2, and how you need that antitoxin plus antibiotics right away. ELIC test for the win.
So yeah, we really went from molars to myocarditis today.
That's the PodBites promise: short, sharp, and stacked with everything you need.
Ladies and gentlemen, that wraps up our dive into oral microbial infections and neoplastic lesions. Thanks for tuning in, and don't forget to follow PodBites for more high-yield episodes. See you next time.